All righty, and we're going to get started this morning. Again, welcome everyone. So our first example that we wanted to start talking about is when we talk about documentation, it's very valuable if we can think about painting a picture to those that are going to be reading the EPCR. So when you paint a picture, it's really looking at the patient's condition at the time of transport and what other information that you have that is pertinent that you know prior to the transport. Also look at what CMS defines as medical necessity. I know this is discussed a lot in the air and ground transport arena, and as a billing company, we look at what defines medical necessity, and we're going to take a look into how that is applicable within the charts that we're using. That's just a point to let us know that the medical records do validate and need to support medical necessity. Our objectives today, and this is a high overview, that we're going to look at how your PCR affects the billing process. How does it validate what has actually happened on the transport? Identify changes that you can make today. We hope that you can take home some key points and use those in your documentation strategies, and that you can share that with your other teammates and then on your orientation practices. Learn some tips for writing some of these high quality PCRs so they don't get bumped back for any revisions or corrections that need to be made. And review any other opportunities that can enhance your revenue. And I just wanted to take one side note that we are going to be recorded. I had a little pop-up screen. Okay. The first item on documentation is I wanted to express that everyone contributes to this piece. We know it's valuable when you're doing your documentation that whoever is putting the information in the EPCR, but it's also impactful for the dispatchers that are actually taking the information in and putting it in the CAD system. Your caregivers that you're getting report from or that you are giving report from. And then of course that's in your facilities, but when you go to your EMS agencies or your scene calls, what information you are getting from those providers also. This is just an example of our best practices. I like that the documentation, these are rules of the road. This is kind of what we look at when we are saying a high view of these are important when we look at our EPCRs. We document before. This can be your prior to arrival and EMS charts. This is also applicable when we're talking about getting information from the dispatch center or those facilities. You don't always have that opportunity, but it is valuable if you can do it to try to document before. During can be challenging too, but we recommend that. And then of course, immediately after. Those 3 points help with painting that picture so that the information is accurate, it's objective, and it includes details that have happened during that transport and they're fresh in your brain. We encourage you to never embellish and over exaggerate on some of your opinions on those things. Don't copy and paste narratives into the PCR. That's a big no-no. Don't copy and paste signatures either. That's a no-no. And write your report, like I said, when the details are fresh within your mind. Next slide. It's coming. The next slide is going to discuss is who's reading your PCR. Of course, your clinician partner that you're transporting with is looking at that. Your receiving facility, your supervisor. Sherry goes in and does lots of audits along with Jessica and the other education members. Your medical director. I know probably Dr. Swanson goes in and reviews any charts too that are looking at that. Patients or families can also look at certain records in the chart. A big thing too is for any type of law enforcement or attorney offices, if you've had an auto accident or there is a legal case engaged, they have opportunities to review that chart. Also Medicare or Medicaid auditors or your local and state registries. Your 7 key areas that paint the picture are dispatch and pre-arrival, at scene and initial contact, loading and transport, handoff destination, patient signatures, and demographics and documents. Crew signatures and credentials. We're going to discuss all of these. This highlights our objectives for our discussion today. Our first area of focus is dispatch and pre-arrival. We're going to look at recording details around the dispatch piece, noting non-emergency transports and dispatch, and documenting timing and mileage. First off, when we talk about dispatch and pre-arrival, we want to look at your response level or your mode. Secondly, we watched what the dispatch reason and possible patient condition, and you can include the EMD code if that is used. Where you delayed in responding, we need to document why you did not come or respond on that transport in the time that was anticipated. Ensure dispatch information is all captured on that PCR, and that piece is the valuable piece that we request when the dispatchers are putting in that information on the call intake process. When we review interfacility and discharge trips, coming from the comm center, we have the opportunity there to initially screen for that medical necessity. And we want to ensure that the patient receives the most appropriate level of service. It requires a CMN. This is our best practice. We request that all of these are requested on each transport. And prior to dispatch is when we would request those. We can also at this time, if you have the opportunity, to review insurance information on prior authorization in the dispatch center. Timing and odometer mileage. Accurate timestamps of when the transport started and when it ended. Adjust for daylight saving times, and we don't really have this challenge here on the East Coast, but also for any time changes if you're going across any time zones, and your accurate odometer readings. I'm going to pause there and see if we have any questions.
Hey, Kim, I would suggest let's hold all the questions either to the end, or if we have time, since we're going to be really, really tight on time. And if we don't get to the questions, if they shoot me and you and I email, we can answer them.
Okay, that works.
But I see Logan's hand up, but since he already did that, you want to go and ask him?
Okay, Logan.
Hey, it's Graham actually on Logan's computer. You said that this CMN is required before dispatch. Almost every time we get sent signatures for paperwork, it's requiring us to fill out a CMN. So is especially on like STEMIs and stuff like that, where it's a time
sensitive. Yes, and that's good. That's best practice is what we request that you do that, even though we know that as an emergent transport and it meets medical necessity because of your time frame. It still supports medical necessity. If you do that every time you're doing it, it is best practice.
Yeah, and I would suggest, if it's a time sensitive thing like a STEMI or a stroke that you're trying to get to intervention, don't delay patient care. I mean,
Right.
This is paperwork. This is for Medicare HMOs, and there are opportunities on the back end to get that, but it does delay revenue. So don't hinder patient care to get that. But if your communication center has the ability to get it either before, during, or after your transport, that is best practice.
All right.
And guys, we're gonna let you put questions in chat if you have them.
Wonderful. All righty. I'm going to let Celeste go on for the key area focus of section 2.
So this is where we start talking about, what happens when you get there, talking about what happens on scene, the patient status, and then we're just going to go over different billing levels of service. And so you can see how we look at the claims versus, how you were dispatched and the care. So the first thing is when you get to the scene, is it, how you were dispatched? If you're going on a scene run, how many patients do you have? What's going on with the patient? If it's an interfacility transport, it's very important to list the diagnosis at the time of transport on your PCR, because we do need to code those claims on the back end with the most specific code of their diagnosis. Any pertinent past medical history and medications, again, medications, a lot of times you guys don't have time to get that, but there are some medications like any of the anticoagulants that do sometimes help tip that claim into the medical necessity bucket, because there may not be enough if it was, for example, like a simple fall with no injuries, but the patient's on anticoagulants. That's something where we could fight for medical necessity because of the high risk due to that medication. And again, like Kim said before, everybody across the United States is looking at these PCRs. So make sure you use a common language. We had some audits in the past, not for your company, but for a different company, where they were using areas that like locations that were only specific to people who lived in that area, what they knew. And the auditors were denying because they just had some questions on that. So just keep in mind that, you know, not everybody is on the East Coast that's looking at this, and make sure that you just are very proper and detailed in your information. So again, like we said earlier, we want to prove medical necessity, and we refer to Medicare because they are the highest, most difficult standard to meet, and the majority of the other payers follow suit with their regulations. So medical necessity says that all other means of transportation must be contraindicated in order to go by ambulance. So you need to make sure that you keep that in your mind, you know, when you're taking these calls in. Even if you don't have a stretcher van or a wheelchair van in your fleet, Medicare doesn't care. They want to make sure that, you know, the ambulance and the medical attendant is necessary, and why. And then reasonableness is, did you go to the most closest, most appropriate facility? So there is a locality rule. So a lot of times, a lot of your trips, you know, if you're going into Charlotte from an outside, you know, hospital, even though you may pass, you know, one, there is a locality rule, but again, you don't want to bypass Charlotte and go somewhere further when the services were available. Now, if there is, if, you know, if you're being sent to a different facility because there's no beds, document that in your PCR, because that's very helpful to prove the reasonableness. So if you're going to one pediatric center versus another because of bed availability, or they're on divert, make sure that you're putting that in your PCRs. So when we talk about interfacility transports, again, current patient diagnosis, what did they do at the sending facility? Make sure you include that. On ground transports, document why they have to go by ambulance versus stretcher van or wheelchair van. And then on air transports, why are they going by air versus ground? You know, a lot of times if they're very short air trips, you know, like under 7 or 8 minutes, you know, a lot of times ground is only going to be about 25 to 30 minutes, you know, when you look at that. So if it's high traffic time coming into Charlotte, put that in your PCR. Anything that affects the reason why air was chosen versus ground. And then what services are needed at the receiving that aren't available at the sending. And this is very important. You know, a lot of places are critical access hospitals and don't have critical care. So you could put something like in your narrative that patient had to go because of critical care, intervention, trauma, NICU, PICU, things like that. Or if a center's on divert for some reason, you know, include that in your PCR, because again, that helps prove that reasonableness standard. Again, for the call center, if you can get the certificate of medical necessity ahead of time and get that filled out, that's awesome. That's best practice. That takes the responsibility off the crews. But again, don't ever hinder patient care to do that. A lot of the Medicaid products require prior authorization from the sending facility. That has to be done prior. Very, very difficult to get a claim paid if you don't have that prior auth. And then there are brokers involved in the Medicare and the Medicare managed care plans in North Carolina. So a lot of those have prior auth requirements. Most of the facilities are aware of that, but make sure that you're documenting and including that information in your billing documents. All right, so when we talk about the transporting unit, what the crew's responsibilities are, again, diagnosis at the time of transport. What interventions did you do? If you put a cardiac monitor on, make sure you put what the rhythm is. Sounds simple, but we see it all the time that they say monitor applied, there's no rhythm documented. That doesn't count if there's no rhythm. Continuous infusions, make sure that you're putting that also in your activity section. You know, there's that section for meds prior to transport. Then there's in the activity section, just make sure that you are individually listing out what you are infusing during transport. If the patient has a central line, peripheral line, arterial line, SWAN, anything like that, document that, and any titration of the medications, because again, that helps us with the levels of service.
Another point to Celeste is talking about when we talk about continuous infusions, I would be mindful too, if you are arriving on a scene or at the facility and you're picking up a patient and you see that an antibiotic is infusing, or that it has been done, but it was documented that it was infusing when you picked up, please be mindful of that also. That can also, we look at what medications were done, if Zofran is going over 4 hours, or was it really a 30-minute infusion? Just also remember that people don't always think about the antibiotics as a high priority medication, but it can help to find some medical necessity on some of those ground transports specifically. All right, I think Celeste and I are both going to tag team this next area of loading and transport. Here we're going to continue to review medical necessity. You're going to hear that and think about medical necessity in your sleep tonight after this presentation. And also, again, when you're transporting this patient, we're going to look at some assessments for pain and your mental status. And that's also going to help us on some of those documents that everybody talks about when we look at pain and what your mental status is on the patient and putting it in the EPCR. All right, the first one here on supporting medical necessity, when you're loading the patient or when you walk into the room, what does the patient look like? It's very informative if we can say on the chart if the patient was moved by stretcher, is what you put in your PCR, but when you walked in, if there's any conflicting information, we want to make sure that what you see is what you're documenting, how you moved the patient, in what manner. Was it a draw sheet pullover? Did they ambulate? Did they sit in a wheelchair and then get on your stretcher to be transported? Is there any special positioning? Do they have to sit with their chest up because they're not breathing very well? Is the patient unable to tolerate transport in a certain type of position? If you could please document all that, that will support medical necessity. Another reason is bed confinement. We need to know why that patient needed assistance and why they couldn't either transfer to the stretcher or anything by themselves. All right, next is an example I know that Celeste wanted to review when we talk about loading the patient, and you can see these areas highlighted here.
Right, so this is an example of, you know, things that you can put in there that help support medical necessity. Again, so there's a lot of information documented here, but I highlighted the stuff that we pull out and we look at. So this patient was found sitting in a wheelchair. So typically, you know, if Medicare sees, an auditor sees that, they say, oh, wheelchair patient doesn't need to go by ambulance. But hold on, you know, stop right there. Patient's forgetful, you know, that's a safety risk. So they stood and they pivoted with the assistance of a walker. So that, you know, you just need to be very mindful that the words that you choose to document need to make sure that A, they're accurate. You know, don't ever embellish, like we said earlier, and say that they're bed confined when they're really not. But we want to make sure that there are things that that you put in your PCR that help support medical necessity. Because on this one here, if you're just looking at keywords like wheelchair, stand and pivot, transfer to a chair, the Medicare auditor is going to say, nope, could go by stretcher van. But you look at patient has a history of glioblastoma, they can be forgetful. If you look for a GCS score, anything like that to add in to help support the need to have the medical attendant. Because again, if you have them in a stretcher van or a wheelchair van, that would be a safety issue because there's not a medical attendant with them. So that's why we just like to point out how words can be interpreted on the retrospectively when auditors are looking at it.
Right.
So you look at this is the same patient. Again, you know, they have some medical conditions that could cause alteration in mental status, but here's the issue. You know, they have all these, they say that they're forgetful at times, but on the mental status exam, everything is normal. So the Medicare auditor is going to look at that and they're going to call out and say, which one was present at the time of transport, because you have conflicting information in your PCR. Again, GCS is 15. There's hip and knee pain, so I would, if I was the crew member writing this PCR, I would put more detail into what the mental status was at the time of transport, and that, the hip and knee pain prohibited the patient from sitting, if that was true, things like that. Add the detail around the reason why they have to go by ambulance.
Okay. The next piece is transporting the patient. We need to document all the interventions, the vital signs, and treatment, as well as anything missed. I think one piece on the EPCR for the application that y'all use, you do have that application there in EMS charts to say missed interventions, and that we haven't seen any concerns with that. That seems to be well documented for Med-Center Air. Did you transport to the closest appropriate facility? Why were you diverted if you were? Was this a patient request, or would you need to document the reason for the diversion? Include the name of your original facility, where you were coming from and where you were going. Remember that hospital discharges must detail what's going on right now. It can't happen and describe what the patient came in with. It needs to be what the current condition of that patient while they are leaving the hospital. The next area we're going to review are levels of service. So I think everybody's very familiar with what BLS and ALS is, and also the ALS-2 and SCT transports. So this is just an overview so that we can show you how we look at what is defined by ALS. So typically it's a critically ill patient who requires medication administrations. They can be 3 different kinds, but it's typically IV or IO. These medications that are listed that are performed during the transport are these are more actions here that are listed, and I think these are very self-explanatory pretty much for our clinicians, because we know this is providing advanced care if this would happen during a transport.
Right, and the big thing here is that if you have infusions that you're monitoring during transport that were started at the sending facility, make sure that you document them in your activity section, because that, if it's not a critical care transport and you have 3 infusions, or you have a total of 3 different types of meds given during that transport, maybe an infusion plus maybe a fentanyl or a Zofran here or there on the ground trips, then that will bump you up to this ALS-2 level. And again, each level of service is a different level of reimbursement, so make sure that your documentation is very clear.
Do you want me? This one is just explaining what SCT is, and typically that is always between facility to facility. And this also defines here, it's an overview of what type of providers. I know within your program that the paramedics have advanced training, and we have aligned with that on the education pieces too. I think there's a side note here too that says not all payers recognize SCT level of service. So it's very imperative that if you can document what interventions that you completed, that is impactful for supporting what level of service has been provided for the patient. For things to consider on SCT transports, state protocols drive the interventions that are performed by the provider that defines whether it's ALS or SCT. We also encourage rosters that have been completed for any of the additional training that we had discussed. These must be updated with your credentials and your licenses and your education. We encourage each program to always keep track of that. I know Med-Center Air does a great job of that. Kudos to the education department too. And the patients must be critical to be transported, and they must meet that necessity to be transported by ALS-2 or SCT. The next area we are going to review is pain assessment. This is a big thing within the Atrium healthcare system, as we all know, of when you document pain, and pain can support medical necessity when you're transporting a patient. So it's important to document the key elements of pain, your dull, sharp, throbbing, location, what interventions were done if the patient had pain, not only medical interventions, but positioning, or was the patient tolerated it, and the response to that intervention. Another thing that supports medical necessity, not only documenting your pain assessment and what interventions, is the patient's mental status. We see a lot when we are auditing charts that the Glasgow Coma Scale will say that the patient is a 4 or a 5. But then when we look at the activity summary in EMS charts, it says the patient is alert, pleasantly smiling. We just want to make sure that your Glasgow Coma Scale matches what you're describing in your narrative. And what was the normal baseline for that patient? Can the patient follow commands? Are there any safety concerns? Is the patient agitated, combative, or confused? Those are all pieces of mental status that can support the patient needing to be transported by ground or air ambulance. I'm going to let Celeste take this one too, so we can alternate on documenting pain and mental status.
So you can see right here again, in the narrative, they have information that the patient's confused, they have a history of seizures, history of altered mental status, and that they, it sounds like they may have had a seizure, they were given Keppra. They go on in their narrative to describe that, that looks like that the patient's being transported because of a seizure. If you go to the next slide, I believe. So again, you look at GCS here, doesn't match. So make sure that, now I'm not a big believer that GCS scores give you the true picture, but just make sure that if you are putting a GCS score on your PCR, make sure that you're picking the appropriate numbers so that it matches your narrative. We have had Palmetto, which is your Medicare MAC, is very famous for looking at GCS scores and looking at narratives, and they will deny claims if there's any inconsistency. So, that's just something you don't have to double document a drop down and a narrative, but if you're saying that one is different from normal, then make sure that the other matches. So just driving that home again. All right, so the first impression of this one, this is a discharge strips, especially to residences or to like assisted livings, are extremely difficult to get paid. So make sure that your documentation, I know these strips are typically very simple from, the levels of types of care that you do. So that's why, you need to just put as much information in there as possible. So you look at this one from a medical necessity standpoint. And his weakness, he needs continuous supervision. He was in the hospital bed. He has a history of dementia. He's confused. There's no pain. We just want to make sure that when you're doing this, you're putting details in there that help prove that the medical attendant was needed and the patient needed to go by ambulance versus another means of transportation. Again, same thing. This one was consistent with what was in the narrative. The GCS matches that. Pleasantly confused, history of dementia. Something simple as that. We're not asking you to write a book. We're just asking that, you pay attention to what you're putting in there. I know it's difficult and that, sometimes it's at your end of your shift and you want to just get it done and get it signed. But again, not only from a billing perspective, but from a legal perspective, if this trip is called into court, sometimes 5, 6, 7 years down the line, you may not even remember that call. Chances are, if it was a standard interfacility transport, it may be just something that, you don't remember versus like a scene run where you remember it right away. So again, we're not trying to tell you this just from a billing perspective, but also from a medical legal perspective.
Thank you. The next item here is just to avoid those catchphrases. We do have an example lower in the slides that we're going to show you that we pulled from the database for MedCenter Air, but When we see transport for a higher level of care, we need more explanation than that. Best to state what type of requirements are needed. Is it that the patient needs a PCI intervention because it's not offered at Union West? So we need to put that in there, and that will help support medical necessity. Is the patient bed confined? Describe what the mobility is or immobility is. How much oxygen is the requirement that the patient needs? Are they on high flow nasal cannula? Do they desat when you change the amount of flow that's provided? This can all support medical necessity too. And then the complaints of general weakness. Best to document why the patient is weak. We see a lot of weakness. Define what that is. Can they not lift up their legs? Are they not stable for a 2+ transfer? Just simple things. As Celeste says, we don't want to overwhelm you and feel like you have to put lots of details in there, but just to remember that these catchphrases, higher level of care, bed confined, requires O2, and general weakness, need a little more support to define what that is happening.
Yep.
Okay, go on to the next slide. It's stuck.
It's coming.
There we go. And we're waiting on questions for that, so we're going to slide into our key area 4 on handoff and destination. The patient handoff. When we are safely unloading and transferring the patient to their assigned room where they are going, make sure to give a verbal report to that staff and then document that in your EPCR. Obtain your signatures from the receiving facility staff member, and please ensure that that signature is legible. If not, ask the signer to add a little printed name under there. We do see some areas where it's very challenging to read it, so just be mindful of that. And you can also leave a copy of that information with the staff. Our next area is going to be getting the signature, who can sign it, and what if they can't sign. I think this is an area of focus that we wanted to draw some attention on, that was brought to us, that was an area of concern. But I have to say, overall, when Celeste and I are looking at the charting and the signature documents for MedCenter Air, that everyone is doing a great job. So this is just for reinforcement.
Right. So when we look at patient signatures, back on the day when I was in the trucks, we didn't have to get signatures. It was just like you took them to the hospital and the payers believed you. But then there were a bunch of fraud cases uncovered for Medicare. And so now a signature is required for claim submission. So we cannot submit a claim. And in Palmetto, Mac, which is where you're located, you have to get a signature every time of transport. So their signature has to be by the patient first or on behalf of the patient before the claim could even go out the door. So again, if this signature is not obtained, we can get it on the back end, but again, takes time. And, a lot of times if these patients are critically ill, we're not going to ever get a signature from them. So if the patient is physically or mentally capable of signing, have that patient sign. That's the first rule for signatures. So can they sign? Are they mentally and physically capable? Are they awake, alert, and oriented, conscious? Do they have full use of their dominant hand and arm? Maybe they had a stroke and can't sign. If that's the case, document that in your narrative so that you can support getting a Section 2 or a Section 3 signature. You guys use the PWW standard form. So when we say Section 1, that is the patient signature area. When we say Section 2, that's the authorized signer. And then Section 3 would be the receiving facility. So signatures can look all crazy like any of these signatures here. But, if the patient is awake, alert, and oriented and physically and mentally capable, get them to sign. So this is one of your claims that I pulled just as an example of how the signature could be, how we should look at it on the back end. So this patient has documentation that they're agitated at the time of transport, their dementia at baseline, their GCS is a 14, and they're confused. However, this patient, for this claim, a Section 1 patient signature was obtained for billing. Now, again, we have the opportunity on the back end to get a different type of signature, but just think about what you're doing when you're getting the patient to sign. If they've received narcotics, it's very important that you document, either an authorized representative or a receiving facility signature, and document that you got that because the patient received narcotics during transport. Again, you don't ever want something to come back on the back end that you got a signature and it's not valid. So we just want to make sure that physical and mental capability of the patient for patient signatures. All right, so does the signature have to be legible? That's a no, but if they make a legal mark, like a check mark or an X or we have one patient in our area that likes to do a smiley face, like if you have something like that, just make sure you witness that, that is the patient's signature. That's what they're putting down as their signature. If the patient cannot sign, then what are your options? So if they can't sign for themselves, make sure your narrative matches why they can't sign. So then you would move on to a section 2, which is an authorized signer. So that authorized signer does not tie them to financial responsibility. So what it does is it just validates that the transport took place. So that could be a family member, power of attorney. Make sure if you're using the authorized signer or the section 3 signature that you're printing the name and the relationship after the signature. If there's no family or guardian present, document that in the PCR and then get a signature from your receiving facility. Again, it doesn't have to be the person caring for them. It could just be someone at the facilities. A lot of times when I used to work in the ER, I would sign as the charge nurse because the nurses were obviously busy taking care of the patient. So it doesn't have to be the primary caregiver signing. And then a lot of times we get face sheets. That's very helpful, has a lot of demographic information. If the patient is physically and mentally capable, but they refuse to sign, document that in your narrative. That patient will get a bill, and then they'll send in a signature form because they don't want to pay that bill. So if they refuse or they tell you that I don't want to sign, that just is our opportunity then to send them that invoice, and then they'll send in a signature form.
Right. Next to our last key area of focus is demographics and documents. So we're going to focus on all the accuracy of getting these details. The first thing is patient demographics. There's lots of times where you don't know the patient's name if it's a trauma being picked up. And we are just here to, we understand that that happens. But if you can, please do everything in your power to get the patient's name and make sure it's spelled correctly. This will help us with pushing the claim out the door and to not slow any type of billing or reimbursements. Date of birth, mailing address, phone number, these are all the things that we need. We definitely have our support in trying to find if there's duplicate patients. Even within the system now, we're more advanced with that, but if we can assist on the initial capture, that helps for sure. Certificate of medical necessity is required by Medicare and most HMOs for these non-emergent transports, but we need to remember that a CMN does not stand alone to say that this transport was meeting medical necessity. The documentation that's provided in the EPCR and that the care that was given, this can also is an additional reason that we need to support. You can ask your comm center if they can send any facility copies to you prior to. That helps also. Medicare considers most hospital transports to be non-emergent and therefore want a CMN. That's why we ask that you do it. It's best practice. All right, certificate of medical necessity for these pre-scheduled and repetitive trips. These are those once per week or 3 times a week for your dialysis patients. Then we strongly that you must obtain a PCS or CMN before that run, and it be signed by that attending physician that supports that this trip meets medical necessity. Unscheduled trips now can be signed by the caseworker, the LPN, the discharge planner. It does not have to be that primary provider that's taking care of the patient, but they do need to have intimate knowledge of the patient's condition or involved in the care.
And just a side note here, we get asked a lot in compliance about having EMS crews sign the CMN form. That is not acceptable. That will be sent out as an invalid CMN because you have to be someone prior to initiating the transport have knowledge of the condition. So technically, you don't have knowledge of what's going on prior to the transport. So just make sure that your CMN is filled out ahead of time. There are no specific forms from Medicare for the CMN. You guys have a great form. It has a lot of information it seems like it's very easy to fill out. But the biggest thing is that it has to have a reason that ambulance transport is medically necessary. So that you could have it on a piece of napkin as long as it has ambulance transport is medically necessary and why, then that would be good. It also needs to have a legible signature. If the signature is not legible, have them print the name near it, and it needs to be dated. The big thing, if you guys do any repetitive transports, again, those cannot be obtained after the fact. They have to be done before the transport. So if you do those, please talk to Kim about the importance of that if you're struggling with that, because those trips, especially dialysis trips, they add up quickly. So we just want to make sure that, you have all your documents together prior to even doing the transport. This is an example how we talked about before for where it says higher level of care. This is obviously one of your CMN forms, so it really doesn't tell you anything about the patient. There's, when you look at this one, the same patient had a second one on the claim, which was helpful, that they needed to go for specialty surgical specialists. So that right there, just having that checkbox in the surgical specialist area gives me more information than saying higher level of care. And then what we do is we look at your narrative and the reason for transport. Again, the CMN does not prove medical necessity. It's just, it helps. It's not, it doesn't, the PCR itself has to document why the patient needs to go by ambulance with medical attendants. So again, this patient needed to go for GI surgery because of, I forget if they had an obstruction, but the center where they were does not have GI specialists. So again, just something simple as a checkbox, that's appropriate versus saying higher level of care. And then prior auths, I know a lot of your Medicaid managed care plans require prior auth. That's something that the communication center can ensure is done prior to you guys even being dispatched. Again, that is required to be done by the sending facility, cannot be done after the fact. And if you don't have the prior auth number, those claims will not be accepted for payment by the brokers. So just make sure that you have those.
Okay. I know we're holding questions, so we're going to go ahead and go to our last area. Crew signatures and credentials. We're focused on our accuracy again and our details. Signature of all members that were providing care during the transport, whether you were in the back providing the care or you were driving, but we do like it for those that actually provided the care. Credentials for each member, we've already discussed that, but we need to make sure that those credentials are added to your signature and don't let your certificates expire.
Yeah, just something real quick there. I know that sounds silly, and you guys have a great QA system and a great, foundation for, making sure that all of these are intact. You're in a big hospital system, but if any of you volunteer or work at other facilities, we've had quite a few caregivers have just their CPR expire. And if Medicare catches wind of that, any trip that you're on during that expired period has to be refunded. So just, it's not only important just to keep it up, for your own professional development and stuff, but it does affect the revenue process if it does expire.
Right. Can you guess what the theme of today's training is? I think we've said some of those repetitive words, but the most important question to answer are, and this is just kind of going to be a slide if you can go over them in your head. Who, what, where, why, and how. And those are just key things to try to help you paint the picture on some of the documentation training that we've gone over. And when, sorry, I did forget when. Who, what, where, when, and how. All right. Good clinical information typically equates to good billing. As we said, we understand that your job is very high acuity, you're busy, you're doing everything. We are just here to give some additional support, training, discuss things we can review again. But we just wanted to give an example of what you can look at and think about the next time that you're going into a patient's room or a scene call and you're charting on your EPCR. That concludes our slideshow. I hope we didn't go too fast. So I'm going to hand it over to Sherry, I think this, right, Sherry? And then you wanted to do questions?
Yeah. I'm going to make mine really, really quick because this is our first time of doing it, so we didn't really know how much it was going to be. So hold on, bear with me. I'm going to try to see the best way I can get this up there.
Okay.
And can you guys see my show now?
Yes.
Okay, so like I said, I'm going to run through this really, really, really quick. But this is kind of like putting the Med Center Air spin on everything. So again, repeating what she said, it's also it's so important for our documents to be accurate because they are legal documents. At any point in time, they can be pulled into court. Also note that certain data fields are required by NMSIS, North Carolina OEMS, and South Carolina DHEC. So basically what this does is if we cover all of the desired validators that NMSIS asks for, we meet all the other for local, state, and national. So that's why we gear all of our education and all of our documentation information based on NMSIS requirements. So what should we be documenting? Everything. Everything is significant. Check over your vital signs. If you see a low blood pressure or SpO2, and you either remove it if it wasn't accurate, and if it was accurate, you must have an action in the narrative that will explain that you witnessed it and what your response was. We do see that a lot now that we have the Zoll that uploads automatically, and we will see some really crazy readings. And then in the QA, I'll go back and I'll say, hey guys, you had an SpO2 of 50, but you didn't do anything. You said patient resting comfortably. So we do look for things like that. Dispatch information. Here are some big things that we have to go back for QMC to get a lot. And a lot of people do not go back and read their chart, and they go into the mindset that if the CAD didn't have it, I don't have to go back and put it. But you must proofread all the information that is imported from the CAD. Do not assume it's correct. You will find sometimes that you're not listed as the crew member. And if you don't put yourself as the crew member, you're going to find yourself in trouble because you're not going to be able to get back in your chart. Also make sure you have a referring facility and physician, a receiving facility and physician. It is your responsibility to ensure that all this information is correct. Little side note, this comes up like every 6 months or so. Let me set the record straight. Mileage is calculated by GPS and does not need to be entered on EMS charts. I answer that at least every 6 months. You can't lock your chart. I get those quite a bit. If you ever can't lock your chart and you see the orange screen Klingon that you can't understand because they can't just write out, hey, go to page this and fix it. If you see 19 element anywhere within that message, go to your referring facility and look right there for your zip code. If it says loading, reload your referring, and then you'll be able to lock the chart. Thank you, and that will save me a lot of time. Back to home transports, we're seeing those more so now on the Beam Road side, but could be on the critical care side. When you are transporting the patient back home, the CAD will enter up here home and with asterisks beside it. There's no way that the CAD can enter the patient's address because we don't have everybody in the state of North Carolina listed in our CAD. So you will have to go in and manually fill this information in. Shouldn't be a problem since you'll have the address to go to that you're dropping the patient off. Now, if that's not their accurate home, they're going to a cousin's house or something, still enter where you took the patient. There's a big change coming about to round trips. Sorry, guys, we have always done, if you've never relinquished care to that patient, that you do not have to do another chart. However, there are more and more insurance companies that are coming about saying, nope, we need two. And rather than saying, okay, if this patient has this insurance or that insurance, this is the pipe. No, we're just going to go ahead, cut to the chase. Every round trip must now have two charts completed, one for each leg of the transport. Really doesn't matter where you stop one chart and start the other. I would suggest that you stop one chart when you arrive and get the patient on the table for the procedure and start the second chart there, or just so long as you have continuity of care. Aircraft assist, anytime there's an ambulance used for a transport of a patient, a chart must be done, with the exception. We've always done aircraft assist for MedCenter Air Team as a third-party vendor. I will get more information out to you as I find out for certain. But right now, I am hearing that we're going to be moving toward, if you assisted MedCenter Air on the aircraft assist, you will not do a chart. All others you will. And I know that might have some questions, but I'm trying to get to the bottom of this to get a definite answer. So look for more of that one later. Just make sure when you go in on page 1, you're looking at the response mode and the mode descriptor. I am seeing quite a few coming in now doing emergent traffic, lights only, no sirens. That's illegal. So go back and look. If you did lights and sirens, you need to have lights and sirens. But I can't tell you, I don't know if they moved the location of some stuff, but I am seeing it more and more. It can be an emergent response without lights and sirens. You're just not letting moss grow under your feet. You're moving, but if you put emergent traffic, you must click lights and sirens. Transport mode, that's for both of them, to and from this facility. I'm going with that one. Patient demographics. We're seeing a lot of increased of trauma names, which is fine. We've had that, always had that. The biggest thing that's coming up right now is people are not paying attention that the CAD imported a date of birth of like 1900. So their patient is 123 years old. Go back and look at that. You're responsible for verifying all patient identifiers and all patient information. So go back and look and make sure if you don't have the correct date of birth, but you were told this is a 36-year-old man, erase the date of birth, put 36. I had one just a few days ago that happened, and they wrote in the HPI patient 19-year-old and date of birth, the patient was 93 years old. That is a discrepancy. If that chart will go to court, the lawyers are going to have a field day with that. So just keep looking at your chart as a legal document. I've got to make it as close to right. If it's not exactly right, QMC is going to contact me. They're going to say, hey, I got the right date of birth now. I can go back in on the billing side and fix your date of birth, but you got to put me in the ballpark. You can't have me a 93-year-old DOB and the patient's 19. NMSIS now is requiring gender and race and ethnicity. This is not, I've had people say, well, I might not know what gender they are. I might not know what their ethnicity. You put to the best of your knowledge what you think they are. We're also getting more identifiers for gender. Patient history, patient chart is not acceptable. Anybody who reviews these charts cannot see the patient chart. So you need to put as much information as possible. If you don't know all the information, you can put just what was reported to you. You are not required to list every past medical history they ever had. I mean, it's understandable. Ambulation condition indicator, again, choose a minimum of 3 to support reasons for patient transport. Let's see, CMS demographics. Your narrative on page 8, I think they touched on this quite eloquently. Your narrative on page 8 should always support the reason you select. If you choose patient as bed confined, but you let the patient walk to the bathroom, CMS is going to actually take this as a contraindication and may even kick out all reimbursement. So think about it this way. Could or should this patient walk down the hall into the truck? And if not, why? Did they receive pain medication? Do they get short of breath? Do they get dizzy when they stand and ambulate? You know, it might not be that their right leg's falling off, but think about, could I let this person actually walk down the hall and get into the truck? I'm gonna keep on going. Chief complaint. It can never be no complaints. If I had someone tell me one time they have no complaints, and I'm like, well, I'm pretty sure that endotracheal tube in their mouth is a complaint. So put either the reason the patient came to the ED or the working diagnosis or actual diagnosis if they've already gotten an actual diagnosis. If it is returned to nursing facility, you can put was it post admission for this diagnosis. For history of present illness, document as thorough history as and increase. We see an increased request of insurance for more specificity regarding symptomology prior to the hospital encounter. The big thing that came up to my mind on this one is we had a patient that had abdominal pain for chief complaint, and the history of present illness just said abdominal pain being admitted for API. Well, there's no ICD for API. We understand it's an appendectomy, but you know, you have to be specific on what you're saying and be clear and concise in what you're saying. So always document any interventions that were reported to you. If they were not reported to you, you're not responsible for it. Factors affecting care, always select some of those. It could help, do nothing but help build your case as to why this person needed to be transported. How they were moved, fill this out, how they sat. I'm not going to go into that again. Getting back to vital signs, any action or intervention performed should be documented as an ad action and not narrative format. If at all possible, this helps us when we do our research. Vital signs are obtained every 5 to 10 minutes if an unstable patient, 15 to 20 if stable. BLS transports per North Carolina OEMS should have 2 sets of vital signs obtained, at least at the pickup and the drop off. Also, something that we've not been doing, if at all possible, North Carolina OEMS calls for the first initial blood pressure to be a manual and documented such. Completing and locking charts. Once you lock that chart, you're saying all crew members are satisfied and that the chart is complete. No chart can be opened again. Any additions to the chart once it's locked should be done by an addendum. All charts should be completed within 24 hours of transferring care to the patient. Any difficulties, you need to email me or Tom McLaughlin. And if you go to lock the chart after we've done it, or if I lock it for you, I always put in there what the difficulty was and that you contacted us. So that, I mean, if it's a weekend and I don't want you calling me on the weekend, just put in there, could not get it done because 19 element. And so I'll go in and I'll fix it for you and I'll close it out and I'll put the reason the chart was late. But you have to have a reason. And I'm just going to caution you that the reason can't be, well, it wasn't my fault. It was my partner's fault and I couldn't get in touch with him. If you make one attempt to get in touch with your partner and they're not responding to you within about an hour or so to get that chart locked and they were the last person, contact your team leader because these charts need to be. In South Carolina, they haven't started stressing this with us, but in South Carolina, as of 2020, any provider that has a chart not locked within 24 hours can be fined. And it's not MedCenter Air, it is the provider that is fined. I've not known anybody they've done that to, but they sent that out. So a few charting tips. You need to document the reason the patient is bypassing the nearest hospital. You might not always know that, but most of the time you can say it is the receiving hospital is the nearest hospital to provide whatever advanced care. If you're on the fixed wing, that can be really challenging because if you're going Maine to Florida, you're bypassing quite a few different. You might go ahead and say things like, it was the return closer to home or something like that, or it was the patient's preference or all that. But to keep in mind, most fixed wing transports, there's a guaranteed pay. And so we usually do not send a fixed wing out unless we've already received pay. Most often this is to help the family. So if they go back and they file insurance, they can look at our documentation and say, this is why they said they flew Maine to Florida without landing in Charlotte to take this patient to a perfectly good hospital. Document any interventions you perform during the transport, even as simple as applying oxygen. That gives us the ability to charge for everything that you do. If a cardiac monitor was placed, there must be an interpretation of the rhythm, at least one interpretation. If you have an IV, and look at this, a lot of people will say check drip, but we had one come back the other day that somebody had IV normal saline infusing at 125 per hour and they clicked drip. In the narrative, they never documented how that IV site looked, how much infused during the transport. So QMC asked me, and I looked back and talked to the caregiver, and he said, no, it was a drip when I got there. I locked it off and I had nothing going. If you check drip, that means that you continued the drip. And there again, if you continued the drip, you must have documentation as to the site and, no infiltration, no pain, no redness, and things like that. When you're documenting pain, follow your PQRST. That's just nursing and paramedic 101, and even EMT 101. For signatures, I'm not going to beat a dead horse because I think Kim and Celeste did a great job on that. Again, if the patient's alert and oriented, able to sign. If they've had narcotics, we've always been told in the past that if they had narcotics, but they're alert and oriented, that they could still sign. But you could do that, but just to cover your bases when you get to the referring, just get the receiving facility to sign as well. That way, if anybody wanted to question, hey, well, they had 550 of fentanyl and you see they're alert and oriented, walking around in the room, you feel comfortable with them signing, you could put that or you could get an additional signature. If the signature is illegible, make sure you witness or have someone to witness it. And if you run across that man that says, no, I'm letting my wife sign it for me. No, he is the person. And you'll just have to tell them that we need your signature. You also, if you cannot get a signature from the patient and you get a receiving and witness signature, it also helps to get your face sheet at the receiving and upload that. And that just is proof that we actually completed the chart, because in some areas of the country, there are companies that will make up transports to get reimbursements. So this is actually proven you did fly somebody or transport somebody. Here's some key phrases. Try not to say stable, 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 because that just kind of beats the dead horse that this person probably didn't need transport. Instead, say things like patient condition remained unchanged. Patient sitting up and looking out the window. Patient does not meet flight criteria. These are things you don't want to say. Patient's being flown for convenience. Unsure why patient is being flown. Patient being flown at doctor request. I'm not making these up. These are things that come from charts. So you want to avoid verbiage like this because that just supports the reason like they didn't need it. Avoid using word like suicide, intentional overdose, speed was a factor, patient ambulated. Instead say ambulated with assistance if that is true. Try not to say psychiatric and try not to refer to drug and alcohol use. EMTALA, if you've done your ACE modules already, then you know this to be true because this was in our ACE modules. I took it straight out of that. Look at this, Emergency Medical Treatment and Labor Act. So this was a federal law that requires the hospital to provide emergency medical services to individuals regardless of their ability to pay, emergency and labor. EMTALA does not require does not require inpatient to inpatient transfer to have a completed EMTALA. This education comes directly from your ACE modules. So what happens here is an interfacility transfer. They are not emergent now. They have been evaluated and treated and stabilized. So that the whole thing for EMTALA was to ensure they got emergent treatment and stabilization. And then again, transfers from facility on the same certificate do not require an EMTALA, as it's just like transferring your patient down a long hallway that involves interstate. So Steel Creek to Pineville, Mountain Island, Huntersville to University, Harrisburg, Kannapolis to Cabarrus, and Sun Union West to Union. So if you're going from one of those places to the other, you do not need an EMTALA. And I encourage you again, if you're being delayed at the bedside for an EMTALA, please do a care event. Okay, so that's all I have. And I'm going to unshare. If anybody's still with us, we can go back through our questions right quick. Read them to you. So, wait a minute, I got it right here. Okay. So Des said that we often don't know why we're needed, and we drive by hospitals to keep it within our system. How should we document that? Celeste, do you have an answer?
Yeah, so like I said before, a lot of times, I'm sure as in the Pittsburgh area, we have like 5 hospitals within 5 miles of each other. They're not looking at, going to 1.1 miles closer. There's a locality rule for Medicare. So if you're going within the same, I think it's like 7 to 8 miles, that same distance, if you're keeping it within the system, I would just, document. For example, I was looking at a lot of some of the air trips that were within Atrium's, going from a smaller hospital into Pineville or into Charlotte, stuff like that. Just what is the reason they're being transported? The ones where you're going to get in trouble is if you bypass, say you bypass a trauma center that's closer or a stroke center that's closer. We had one that the stroke center was on diversion. I think it was their CT scanner was down or something to that effect. So any like detail as to why you bypass, put that in your PCR. But really, technically, you should, for Medicare and most payers, you need to go to the closest facility. So it's always a struggle when it's within a health system, but do your best to keep that, keep it, truthful. You don't want to, make something up, because that'll just come back and haunt you on the legal side at some point. So
I think one of the questions that was brought up another time was like, well, we go all the time from Shelby to CMC Maine for a code STEMI, but we bypass Caramont. Would it be appropriate to say to a higher level of care with surgical intervention?
So Caroline doesn't have surgical intervention available there? Like, do they not have, like, is that why you bypass it?
I think they do. I think they do open heart, but
it's not emergent.
Yeah.
Yeah. Yeah, you could do that.
And guys, don't raise your hand. Please just put your question in the comments.
Yeah, a lot of times, like when I'm doing appeals, I reference, like, do they have 24-hour surgical capability? If they don't have that helps with medical necessity and reasonableness, because if you're going to a center that only does caths Monday through Friday during daylight hours, and they don't have ability to do open heart, that you could support that.
And I would suggest too, if you don't know, if you can't figure it out, ask them, hey, why are we going there? And I mean, just
yeah, and some I've even seen on the appeal ends where because a lot of times for appeals, I do all air appeals. A lot of times I get the sending facility records, and I'll find in there that maybe the surgical provider wasn't available at the closer facility. They're already involved in a case. We had that recently with one of your ECMO cases. That they were already within, like, or I'm sorry, it was a AAA, that the vascular surgeon was already doing a case. Stuff like that. That's very important to keep in there. Again, it helps get that claim paid on the first go around instead of trying to appeal it and get it paid.
Right. The next question, just to confirm, neonate transport.
Can I just
Neonate
add to that,
transport
though?
should be listed as a bed confined. So, my answer to you, Ben, is can your neonate get up and walk? I don't think they can, so I think that justifies being bed confined. Would y'all agree?
And I would just document how you transported them, isolate,
Yeah.
neonate, pedimate, however you did that. And plus, it's a safety issue. You're not going to put a neonate on a stretcher without a medical attendant.
Right, right. And I think that's the big thing, Ben, on that one, is to just draw that picture of how you transported that baby to justify all that you did for them and the isolate need, and did they need pedimate versus all that. I think that's the bigger question. Graham said, many of our patients are happy texting when we arrive and are perfectly happy walking around the room without assistance. How should we be charting these types of patients that really don't need ambulatory assistance?
So, just because a patient's ambulatory doesn't mean that it's not medically necessary. Again, some people need to go because they need cardiac monitoring. They may need pain medication en route. So document truthfully, how you found the patient. If you see that there's a facility that constantly is calling for an ambulance transport and truly the patients have no medical reason for an ambulance with medical attendant, then you need to take that up with Sherry. They can raise that up to the sending facilities that are doing that. We've seen that frequently, especially during COVID when they were trying to decompress places. But again, document truthfully. And if you're noticing that, you're being sent to places, send that back to your communication center and they can maybe ask, more questions to get more details.
Right, right. Jessica's asked, talking about 3 infusions or administration for ALS2, does the infusion of normal saline 20 of K at 125 hours count and then counting the Zosyn, then I gave Zofran, all those things equals 3 to be able to charge for ALS2.
Yeah, so as long as it's something that if it's a medication that you're administering during transport, not that was done prior, those all count into ALS2.
Good, good. Let's see, Julie said, we've been told if a patient had received narcotics, that wasn't a reason we could. Okay, so I think I answered that one a little bit in mine. Again, it depends on how much they received, their level of consciousness, but as just a fail-safe, it doesn't hurt to get a receiving facility signature as well to back it up. Is that correct, Celeste?
Yeah, use your judgment. Some people can take 50 of fentanyl and still be normal. Like I get 50 of fentanyl, I'll be like unconscious. So yeah, just use your best judgment. If document the patient was awake, alert, and oriented. But again, it doesn't hurt to get the receiving facility signature there. But if there's any alteration in mental status, then I would definitely not have the patient sign.
Okay. Jessica again, for patient demographics, specifically for medicine or air, who is responsible for the address, insurance info, and some of those details? Clinicians don't put that in the EMS charts. I'm going to jump in on that one. We don't always get that. The biggest thing, a really helpful thing that I'm seeing is if you have an address, put it in there, because sometimes the demographic sheet will have it. This helps us. It helps, I think, QMC to be able to identify patients, because if you got 50 John Smiths, it might be narrowed down to 2 that live at this address. Same with date of birth and all that. I don't think we're not required to get insurance information or put that in. Do y'all want to add anything else on that one?
Nope.
No, I support you, Sherry. If you have the information, it's not there, please put it in. If you don't, and you can obtain any documentation like a face sheet, that's great. You can do that too. Anything that would assist, we would encourage you to do. But if it's time sensitive, impedes patient care, as Celeste said, we still need to remember that the patient care is number 1. So.
Yeah. And I'll pass along to you. I'm working on one right now that is really difficult. All we had was the trauma name. We didn't have the trauma number. Again, they said it was a 19-year-old male, but the date of birth said 93. They didn't check male or female, but they said in the narrative it was male, and it was like a mutual aid type thing. So we are looking at, we can't get reimbursed for over $40,000 because we cannot find this patient. So that is like heartbreaking for us because we can like to get paid so we can get equipment and pay you guys and things like that. So if anything you can find that you could put in there that can help identify us, where we can go to look for stuff, it really helps us with the billing side.
Yeah, and some things that we look at, you know, what police agencies were on scene, because they're going to get a report and they're going to follow up on that also. That's helpful. You know, any mutual aid companies on scene. Sometimes, you know, you have the name, but they have the date of birth and stuff like that. So,
Okay, so I'm looking at Des and Ash. Well, Des's questions. So if you don't know the age, the trauma sticker age, no, this is coming from, usually it's coming from the CAD, because if you don't know the age on those traumas, it reverts back to like 1900 or something like that. If you know the patient's name, we'd rather have the patient's name than the trauma name, because what happens is once they come in, like they're Oklahoma trauma, and but they have the trauma number that starts 303 something. But once they get the patient's name, Oklahoma trauma goes away, and they're never listed as Oklahoma trauma again. So if we can only have one thing, trauma number is the best thing. If you know for sure the patient's name, the name, even if the spelling is wrong, is good. That way we can match up. Is this trauma number and this name, do they match? It's a game we have to try to play to put all these pieces together to try to find these right people. But yeah, once they identify the trauma patient, that old trauma name just disappears. So if you have choices, get us the number and their name. Ashley Dudley, yes, you may have, we're actually taping this whole thing and we'll put it up, and I will also put the PowerPoint presentation up so that you can review it. We will house, Jessica said we will house these. Yeah, okay. Jolie again, when are we going to be allowed to chart these 5 to 7? Okay, so that is a question that we aren't here to take up. We can talk with you, your team leader, about this. We understand that you have 5 to 7 ground transports, and but what our requirement is, we have to get the charts done and we have to get reimbursed. And so this educational piece is to show you how to improve getting our reimbursement. So we can talk about that one later offline. Not every clinician knows day to day the capability, and these interfacility trips have already been arranged. Y'all have.
That is true. I've noticed this too, but a lot of times this is just if you can do it. If you're getting report at the bedside and you're going interfacility to interfacility, you can ask that primary caregiver, why are they being transported to CMC Main? And normally hopefully that caregiver can tell you, but if you can't, then you can only document what you know. But if you can ask, see if you can have those as one of your questions on trying to paint that picture.
Okay, Des said our system is keeping it in the system, and I can't justify their decisions, yet we seem to be held responsible. You're not here to justify why they're keeping it within the system. You're here to just document why why you're selected to transport. I mean, Celeste, do you want to?
yeah, no, I would just document, like I said, document truthfully, what's the diagnosis and what are they going for? And if we notice trends that, we're seeing denials because of reasonableness, we'll get together with your admin team and just talk about that. We've had that happen in some other larger hospital systems in Ohio, where we've had to talk to them about, like, you can't be sending them, bypassing multiple facilities if that's the payer. These are payer rules. These are not QMC's rules. So, we just want to make sure, and it is hard. It's a struggle. I worked in the UPMC system for years and we fought that all the time. So just, again, document truthfully and let us handle it. If we see any issues, we'll raise them up with your admin team and go from there.
Right. And they have to, QMC has to kind of bridge the gap between us and CMS. So that is in their realm of things to handle. Jen said, chart in the ALS rationale box, cardiac monitor, IV drips, ventilator, etc. If they're on, yes, that is still okay. Are all Atrium hospitals under the certificate of CMC Maine? No. I don't think I had CMC Maine listed on there, did I? Because I think that's South Park and Providence, if I'm not mistaken, but I'll try to find that out for you, Michael. Mike Diblick said, please define the level of care check boxes. Does this apply to crew configuration or level of care?
I'm not sure what the level of care check boxes are.
It is level of care, because you could have a critical care team, Mike, that goes to, like for instance, let's say you're close to South Park and they send you to South Park because everybody else is busy and it's a BLS transport. You're going to put it to BLS level. You may have a critical care configuration, but the QMC is only going to be able to recoup billing for a BLS transport.
Yeah, whatever interventions are done, document the interventions and we'll figure out the level of service.
Yeah. Yeah, and they do that. They do that all the time. They'll reach out to me and they'll say, "Hey, I noticed this ALS transport had Levofed hanging. Can you advise if this is a critical care versus the ALS transport?" They look on the backside and kind of look backwards and see what's going on. It won't let you lock the chart. It's not supposed to let you lock it at the default. But I found out the other day, it's if the default is over 100 years old, and for some reason this guy's was only 93. I don't know. I did put a validator that it wouldn't let you if it was 123. So I might have to go fix that. But it's supposed to come up and ask you, are you sure this person is this age? So anybody else got any questions? Did I answer your questions okay? Oh, Cassie, thank you. All right, there's some really good questions here, guys. And look, you might be starting to think in the back of your mind now as you start charting. Feel free to throw me an email if you have a question, or if you're putting something in and you say, "Hey, is this the way we do it?" I don't mind. Just shoot me an email.
And I'll be very honest with you guys. I look at hundreds of trips a week. You guys do a great job documenting. I'm not just saying that. Like, you know, your critical care documentation is spot on. We're just trying to give you ideas to, you know, just make it better. You know, we don't want to become complacent. Just make sure that, you know, you keep attention on the detail, so that you guys get full reimbursement.
Okay. And then Jessica and Sherry, if you want to stay on, because I know we talked about when I stop recording where that's going to go to, and then we can look at that.
Okay.
All right. Well, thank you, everyone.
And we do have your name on the roster, so you'll get credit for attending this.
All right. I think anything else? We appreciate your time. I hope everyone has a good rest of their Wednesday. Bye-bye, everyone.
Bye.
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 Okay, I'm going to stop recording. Let's see.
Yeah, because we found out if you don't stop recording, if you put this up, everybody hears all the talk afterwards.